Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So today's Grand Rounds are being presented by Dr. Shawn Kelly. Dr. Kelly is a pediatrician and addiction medicine specialist who was born in Ottawa and did his residency in pediatrics in London, Ontario, followed by an addiction medicine fellowship at Boston Children's Hospital. He's since become an integral part of the healthcare landscape in Ottawa, serving as a dedicated community pediatrician. His passion for addressing the complex intersection of pediatrics and addiction led him to take the role of director of the Ottawa Adolescent Addiction Clinic. He also contributes his expertise as a member of the Substance Use and Concurrent Disorder team at CHEO, and his current research projects are centered on contingency management strategies and using family-based interventions in adolescent substance use disorders. And we're very excited for him to speak today on CHEO Substance Use and Concurrent Disorders Consultation Service. Welcome, Dr. Kelly.
Okay, thank you. Sorry for the rough start this morning. I am testing hotel Wi-Fi here and seeing how this goes. So, but thank you for the opportunity to present with everyone, and I really appreciate that. And are we having okay video transmission here? All right, fabulous. Okay, well, welcome to Grand Rounds. And today's talk is titled Adolescents and the Overdose Crisis. I am a proud member of the Division of Community Pediatrics, and I'm grateful for the opportunity that I had been given to work with the Substance Use and Concurrent Disorders Division of the psychiatry faculty presently, and enjoying that very much. And so welcome today, and we'll see if we can get some things. Thank you for the land acknowledgement. I wasn't sure if I'd have to be prepared, and I found it an interesting exercise to go through and try to create my own, so that was worthwhile. But today's learning objectives, hopefully we will cover in sufficient detail, understanding what is going on right now with youth specifically and the addiction crisis that is occurring. And we're going to look at differentiating the withdrawal syndromes of benzodiazepines and opioids and how to initiate some treatment when we have the opportunity to do so. We're going to look specifically at some of our options within the opioid world in terms of both withdrawal treatment and then further engagement in care or medication for opioid use disorder. And we're going to talk about this contingency management, which I'm not sure if it's super well named because it doesn't say much as to what it does, but we're going to talk about it a little bit and how it's being implemented in substance use treatment, specifically for adolescents. So, I am the ultimate free agent, and I don't have any conflicts to disclose. I imagine we'll probably wait for questions at the end, but if there's anything that comes up and it requires some clarification, please let me know. I tend to be a little stilted occasionally, interrupted occasionally, and halting when I'm giving presentations. I promise I'm better with patience, but please don't hesitate to interrupt. Don't let that. I'll interrupt myself, so I encourage you to do the same. Okay. I think a quick note on nomenclature is important. This may be relevant. There's a few terms that we'd like to dispense with, and a few terms and some suggestions for what to replace them with. So despite my specialty being addiction medicine, we try to avoid that word when possible. And we like to use the DSM-5 substance use disorder and the various levels that are associated with that being mild, moderate, and severe. Don't like to say addict or drug user anymore. We want to use that person first language and person who uses drugs. IVDU or IV drug user or junkie, God forbid, we want to say person who injects drugs or substances. Both terms, drug abuse and drug misuse, cloud the waters. I find them to be murky terms, and they don't really have clear definitions. There was a period of time when I was working on the terms and definitions subcommittee for ASAM, trying to clean up the glossary. And these are terms that we hear, but don't add much to the conversation. And there is a little bit of judgment associated with them. So drug use or substance use is perfectly acceptable, either or. We don't like to say relapse anymore. Clean and dirty, abstinent using, those are the terms we like. There is a star here, and it's important to know that sometimes people who use drugs will refer to themselves as addict or drug user. It's not a great opportunity to correct that and tell them tell them what they should be using instead, because there is some meaning in those terms, especially in the 12-step sort of AANA type of communities, where these terms actually carry some meaning and some importance, and they can be used by members of the community for a purpose. Okay, let's go back in time a little bit. Back when there were newspapers and headlines like this that we would read, and it was about 1999 when the first headline regarding the opioid crisis was first met. Since then, there have been countless headlines, countless articles on the and countless clickbait articles, countless exposés and reports on CNN and what have you about the opioid crisis. And they continue to this day. When we talk historically about the opioid crisis back in 1999, that's when we discussed the first wave of the opioid crisis. This was largely driven by a available supply. I don't want to use too many pejoratives, but an available supply of prescription opioids. In Canada, this was primarily oxycodone. In the United States, it was both oxycodone and oxymorphone, which is Vicodin, which we never had. And there was a significant rise in overdose deaths associated with the use of these substances. This was also around the time of sort of the, we can think about the Sackler family and the recognition of pain as the fifth vital sign, and that sort of marketing campaign that has been well documented in such Netflix shows as Dope Sick and the other one I can't remember with Matthew Broderick. But nonetheless, there was a problem that occurred, and there was some attention on it, and there was a decrease in the prescribing of prescription opioids, and there was an attempt to get people off these prescribed opioids and try to reduce the supply that was available. Unfortunately, that isn't a super effective strategy to stop the supply when the demand is very high. And what happened was the second wave of the opioid crisis. This supposedly started in 2010, where there was a significant rise in the amount of heroin in the population. This was largely driven by people who were addicted to other or prescription opioids that were moving over to heroin at that time. Lo and behold, things moved along. They were starting to move a little bit quicker. And by 2013, there was a significant increase of fentanyl that arrived on the market and actually significantly displaced the supply of heroin, probably because the volume required of fentanyl is much less in terms of smuggling over borders and using that, such that it significantly displaced it. It's a stronger opioid, and now these days there is no such thing as heroin in most communities. And we also talk about fentanyl and its analogs, or high potency synthetic opioids, may be the acronym that you see. Okay, so these were the initial three waves. Depending on who you ask, we may be in the fourth wave of this time, or I think that's accurate. Perhaps the fifth. I think the fourth is the most reasonable way to describe it. And so it is ongoing. This is some wonderful data from Health Canada that shows the deaths from opioid toxicity in the first half of 2023. This report came out just in December. And we see that there is a significant spread in where these deaths are happening, and BC and Alberta have been hit the hardest. In Ontario, we are roughly at the average. Just how the numbers work out, this number per 100,000 is actually also approximately the number of opioid deaths per day that we're seeing across Canada. Right. And so this report looked at what's been going on now, and we see that young males are at the highest risk for opioid overdose at this time, and high potency synthetic opioids are the story of the day, and I think that's really important. And now opioid overdose has surpassed car accidents as the #1 accidental fatality, et cetera, et cetera. There's a lot of take-home points, but things are not getting any better, and they didn't get any better during the COVID-19 pandemic. This is probably important take-home, and this is what I'd like to talk about, because this is why we are in the fourth wave. It's not high-potency synthetic opioids alone anymore. Multi-drug toxicity is the rule now as opposed to the exception. So what we see is that of the overdose deaths that we've seen, more than 50% of the opioid overdoses involved cocaine or cocaine and methamphetamine. And this is very important. And there's also a significant portion of these deaths that involve benzodiazepines. So we're talking certainly the rule and not the exception any longer. Okay. Let's see. This is to look at our being pediatric providers slice of the pie in terms of the opioid toxicity. I think it's worthwhile to think of the last two sections being the 0 to 19 and 20 to 29, because those people have had recent interactions with the pediatric world, regardless of their age in that bracket. And what we see is that there's actually been a significant proportional increase of the older half of things, and so it looks like things have gone down for us a little bit, but that's a relative skewing, and things are not getting better for the younger people on the pie. Again, this is some data that is really specific to young people looking at opioid overdoses, and what we have seen is that it's more common to have opioids plus another substance in youth. The bracket for youth in this study was 25 years of age. Involved in overdose as opposed to one or the other, and stimulants lead, and benzodiazepines get the silver medal in this. Okay, now we're going back. So we had some national data, we had a little bit of US data for young people, and now we have some very recent Ontario data, or very recently reported Ontario data. And what this shows is that in the second youngest age bracket that they were looking at, the 25 to 44 age bracket, during the COVID-19 pandemic, there was a significant increase in opioid overdoses. The yellow line is a pretty important line. This looks at opioid agonist treatment for these people, or for this age group, and it's actually fairly consistent. It looks like it didn't have much of a change during the COVID-19 pandemic. When we look at the youngest age bracket, again, not a significant change during the COVID-19 period, but there is a worrying trend. And what we see is that young people are having less access to opioid agonist treatment overall. And that seems to be going down in a significant way without any clear reason as to why that is happening. So I decided we'd bring a guide with us for the rest of our journey through some of the, hopefully, points that we can take home today. And this is a case very closely based on a patient of mine. And we'll go through some of the, certainly learning I did, some of the mistakes that I made, and some of the best practices that we've been able to make some difference for this young man, hopefully, and we'll see. Spoiler alert, I suppose, but very good. So I'd like you to meet Jay. He's a 15-year-old boy, lives in a well-to-do neighborhood, his mom, dad, and his younger sibling. He was an incredibly interesting young man to meet. He was engaging, and he was eloquent, and he was a lot of things. And he had this creative writing hobby, and it was wonderful to read some of the things that he wrote. He has a little history of some sertraline use in the past, and he came to clinic because of cannabis and benzodiazepine use. So our assessment showed that there was some benzodiazepine use, and he would qualify for benzodiazepine use disorder or sedative use disorder, benzodiazepines, mild or moderate. However, he seemed to be in a period of early remission for that treatment, and we didn't engage fully with that because he had stopped by his report and by urine drug screening. Jay was motivated to stop using nicotine and cannabis. So we did the Dr. Kelly or Ottawa Addiction Clinic special, and we had a social worker at the time, and Jay and the social worker were engaged in some CBT quite frequently. We also did motivational interviewing. We did parent guidance sessions, wherein just the parents and I would work together, and we talk about limit setting and how to encourage the kind of behavior change that we wanted in the home, as parenting adolescents is difficult, and parenting adolescents who use substances is incredibly easy to get our purposes crossed. He was also given bupropion for his nicotine use disorder, and N-acetylcysteine for his cannabis use disorder. And hopefully things went really well. Unfortunately, they did not. Whoops, pardon me. Jay engaged well in treatment, and he was bad things didn't happen too much, but he did have a brief seizure, possibly due to the bupropion that we had started. So that was actually discontinued. He had a wonderful evaluation by neurology, and there was no need to continue on anti-seizure medication at that time. He did, however, have some success with the issues that he brought forth, and decreased the intensity and frequency of his cannabis and nicotine use. Unfortunately, something else happened, and the initial denial of benzodiazepine use, while it may have been true at the time, was certainly not true now. And Xanax was what Jay had been using as much as he could, essentially, with the money that was available and the requirements on his time as a 15-year-old. And he was of two minds about cutting down. He knew that this wasn't a good thing, but he was very scared about the effects of what might happen, because when he was without benzodiazepines for a significant period of time, he had symptoms. So this is a nice little Google searchable graphic for the symptoms of benzodiazepine withdrawal. But the symptoms of benzodiazepine withdrawal are the opposite of the symptoms of benzodiazepine use. You don't feel very good. And they happen in a lot of different directions. And so to take this from a nice little graphic to a useful metric, we use what is the Clinical Institute Withdrawal Assessment scale. And so typically this is what is referred to as the CHEO. And there's a CHEO AR, which is typically the most used version of this tool, even for benzodiazepines, despite the name including the word alcohol. There is also a CHEO B, which is a benzodiazepine specific tool. I think both are very useful, and in certain settings, both should be used. In terms of the clinical decision-making that we were able to do at this time, the CHEO AR is actually the tool most frequently referenced and used for number cutoffs as to when we should be treating a patient. And so what we do is we score 0 to 7, some subjectives and some objective symptoms, and we sort of see where we're at with the time, and we decide what we can do in terms of when is it appropriate to treat. And so typically, depending on your protocol, a CHEO of 12 or over is a significant marker where we should be engaging in some significant treatment to try to drive the symptoms down so that we don't deal with the most severe consequences of benzodiazepine withdrawal, being seizure, prolonged seizure, death. Why is this happening? So I guess I'm trying to make a bit of a good mix of the important science, but I don't want to get too far into the cell. So we're going to just try to stay at the cell membrane if we can, as much as possible. But we have to look at the GABA receptor. Benzodiazepines act at the GABA receptor. They don't, they potentiate the action of GABA. They don't actually turn it on themselves. They have a separate binding site that is typically on the GABA A receptor subtype. And in the subunits we look at between the alpha and the gamma subunit, and that's where the benzodiazepines bind. There are lots of other places where anesthetics bind, barbiturates bind, alcohol binds, but what we're talking about is the potentiating of the action of GABA, which opens, and we get this influx of chloride ions, which tends to be inhibitory. These neurons are located all over the CNS. Almost well over half of synapses by the report contain some GABA receptors on the postsynaptic neuron. Okay, what happens when we have sort of long-term use of benzodiazepines is that our body compensates. They try to turn down that potentiation effect of the GABA, and it is partly a number of GABA receptors, but partly a function of the GABA receptors that is decreased in both cases in order to decrease that inhibitory stimulation that is occurring when GABA is at inhibitory force. Inhibitory stimulation sounds a little muddy. Sorry, I apologize, but nonetheless, this is a site that uses alcohol as the agent of choice, but I wanted a scale, and this was the best thing I could find. So what we see is that when GABA is pressed too hard, we have a compensatory action. And then when this GABA potentiator is removed, we have an imbalance, and we have a significant excitatory burden that is occurring all over the CNS, right, where all the receptors are located. Okay. So what do we do for benzodiazepine withdrawal when our CWA gets above 12? Well, we treat it, and our options for treating it are primarily benzodiazepine, okay? And depending on the hospital, city, protocol, what have you, insurance, when I was working in the US, you would maybe make a selection about which benzodiazepine to use. Typically, we're talking about lorazepam or diazepam, longer-acting benzodiazepines or medium to long-acting benzodiazepines. And they're talking about these kind of doses, 1 milligram for lorazepam and 10 to 20 for diazepam, depending. But very importantly, we want to have these people in a non-stimulating environment, and we want to try to make them as comfortable as possible, and whatever that means to them. Additionally, sometimes we don't want to, we want to use enough benzodiazepine, but we don't want to use too much benzodiazepine. So 5 milligrams of diazepam is probably inadequate. We probably need to increase that if that's what we're using. But if we're using 10 or 15 milligrams of diazepam at a reasonable dose and frequency, but the person's still presenting a lot of symptoms, that's when we might reach to some of our adjuvant medications. And typically we're using something like clonidine. Clonidine, I guess specifically if we're looking at if somebody's having a significant hypertensive response to their benzodiazepine withdrawal. But additionally, it's sort of a general use agent, and when people are feeling kind of rotten, that's what we use and add to the mix. And sometimes atypical antipsychotics are very useful in this setting as well. Okay, so it's not that hard. These are medications that are simple, and by the end of this talk, you'll realize that this guy's not that bright. So he's probably like, there's nothing complicated about what I do. It's all quite simple, and I'm sure that armed with a little confidence, I'll be very good at treating this adequately. Okay. But that's just the treatment of the withdrawal. And how do we send them home with a bottle of diazepam? This is the great debate. It is incredibly difficult to deal with benzodiazepines as the substance use disorder for benzodiazepines. So in the adult world, typically people are brought in as inpatients and tapered down in a rapid or slow way, or they are in a very strict outpatient setting that has a significant amount of monitoring where this taper can happen. This taper can take, there can be rapid tapers as the article above suggests, but sometimes these tapers are incredibly prolonged. One patient that I work with in the adult population took 18 months to fully taper successfully from her benzodiazepine use disorder, and she was a highly motivated patient. It is really unpleasant, and it's very difficult. However, there are settings where we can do different things, and we can try to taper a little bit more quickly. Perhaps this is the subject for another talk, but over a few days, and eventually this person was discharged and the taper was continued in the outpatient setting, we can have a fairly rapid decrease. This is just a case report, but there's many case reports of relative rapid tapers. This was done from Saint Justine in Montreal, so by a colleague. So it gives hope to making this a little bit more successful. And there is actually even some more hope these days of using things like phenobarbital, where we can actually have a much more rapid taper because of the really long half-life of phenobarbital, and the sort of 5 half-lives being 30-something days, I believe, for phenobarbital. So there can be an auto taper and what have you. Subject for another talk another day, if you'll have me back. but so this is Odysseus, and this was where we were between a rock and a hard place, and that's where it feels like when we're tapering benzodiazepines, because if we go too fast, people will just supplement with street available benzodiazepines if they're in the outpatient world. There is no place to put them inside in a hospital. I don't think there's capacity to be having all the kids who would need to be in and to keep their motivation up and to do this in a safe way. So what do? Sometimes you get stuck. And with Jay, I got stuck. So we eventually got to a place where, long story short, he's on 1 milligram of clonazepam twice a day. And that's been very difficult. Things haven't gone particularly well for Jay due to his involvement in the procurement and dispensation of interesting substances. He was asked to leave his school and had to go to a new school where the problem is worse. However, I guess from a benzodiazepine standpoint, his urine drug screenings have just shown clonazepam and metabolites of clonazepam and none of the alprazolam that he was using previously. So I guess that's good, but not really, because now Jay has been using a significant amount of hydromorphone. This coincided with a great increase in the availability of Dilaudid that happened sort of all across the nation, but very specifically in Ottawa. There was, in response to those numbers in Vancouver, where we had incredible amounts of overdose due to high potency synthetic opioids, there was a desire to try something. And I think it was a well-intentioned desire to try something. And I think it's actually a good thing to try. But around this time, there was some significant safer supply programs that opened where people who were using fentanyl could be given alternate opioids. They would be given a safer supply of prescription Dilaudid in the amount that they required. And there was no significant, no real limit on that. Oh, there's always an upper limit, but the upper limit that has been used sort of nationally at the time was 30 doses of 8 milligrams of Dilaudid daily. So people in these programs could get a handful of pills. And unfortunately, this led us back to 1999 in a hurry, and we had a significant oversupply of medical grade, which implies safety to a lot of young people, opioids in the high potency opioids in the community. And from a different presentation with the Canadian Society of Addiction Medicine, I had looked at my last 15 diagnoses of opioid use disorder, 10 or 11, sorry, I apologize, 10 or 11 of which the opioid of choice was hydromorphone. The others were fentanyl. And so there was this drastic change that happened as a unforeseen consequence of these programs. And Jay was it's not a casualty. Jay was affected by this change in policy and change in supply. So, pardon me, I'll put that soapbox away and we'll come back here. So, what happened when Jay didn't have opioids for a significant period of time? He would go into the stages of opioid withdrawal. Opioid withdrawal has various stages that occur at various timelines, but depending on which opioid we're using and depending on the half-life of that opioid, the withdrawal symptoms can start 4 hours after the last dose, up to 72 hours after the last dose is taken. And typically, the rotten feelings that we have with opioid use disorder, maybe on the surface, when we look at them a little bit, are not terribly different from what you might see with CHEO, but I've got a little chart to break that down a little bit. What we use for opioid withdrawal is the clinical opioid withdrawal scale. This is a similar scale where we grade things on a variety of point scores. I tend to use MD Calc when I'm doing it at the bedside or at the table side or chair side to look at the score. So what's happening on a receptor level? A very similar, very similar compensatory mechanism is at play. When we have opioid receptors that are significantly stimulated by exogenous substances, what we have is more a decrease of the number of opioid receptors on the cell surface, rather than a change in the function of those receptors. So it's a little different than the mechanism by which we have some changes in benzodiazepine use. However, when we have a abrupt cessation of the opioid supply, or the exogenous opioid supply, what we have is an underaction on the opioid receptors that are located in a more select regions of the CNS and GI tract, but I don't think that's germane to our discussion today. So when we look at these two tools, there's a few symptoms that come up, and people feel rotten and look rotten. And if you just walked by the Emerge and somebody was kind of writhing in a bed, you wouldn't necessarily know from what they were withdrawing. So if we kind of bring what is common to both lists into the middle, and then we see somebody who is feeling unwell and gross and sweaty and agitated, so that it's that undifferentiated picture. But if we look at the periphery, then we see a little bit more of how we can differentiate the two. And these are the lists that are really important when somebody who's been taking both is potentially withdrawing from more than one thing, or is potentially withdrawing from one thing, and we need to figure out what that one thing is so that we can treat it without putting them in further danger of respiratory depression. And so for the CHEO, we tend to have, possibly due to the widespread distribution of the GABA receptors in the CNS, we have these very, I don't know, I feel like this is sort of the pink elephant type stuff. And we have tactile disturbances, and there is hallucinations, and these people are confused. With cows, we have a little bit more head and neck stuff that is useful for helping. They have the runny nose, they yawn quite frequently, bigger pupils than would be expected. And so there is a way to differentiate these two things. In my experience, these lists are very useful. The best way to differentiate what withdrawal syndrome somebody is going through is you ask them, and they'll say, no, it's benzos, or no, it's I'm dope sick. They'll tell you, and they know just as well as this breakdown of the lists is. But that's sort of I don't know. Somebody told me to do that, and I did it, and since then it's been the most useful thing for me. And so, while it does seem a little bit difficult to differentiate, there's a couple of good ways. Okay. How do we treat opioid withdrawal? And the answer is with opioid. But we have options here. We can use full agonists, and that can be something like hydromorphone or methadone, or we can use partial agonists, and we'll discuss this a little bit. Sometimes there's some significant GI specific symptoms, especially in opioid withdrawal, that merit some treatment. And ondansetron and loperamide are perfectly useful agents in that regard. Clonidine, again, is for that just sort of general malaise. I was going to say ennui, but I think it's malaise that we're looking for. And can we use benzodiazepines in people who are going through opioid withdrawal? The answer is if you must. If it is between somebody leaving the hospital in a patient-directed discharge and not having their significant cellulitis treated versus a small dose of a benzodiazepine, I think that the dose of benzodiazepine in a monitored setting is probably a much more a proper course of action. So it's certainly to be thought of at the end, and to try to address all of the other things that we can. And but please don't think of it as totally contraindicated. It's just sort of contraindicated. Okay, back to the receptors. Partial agonists, full agonists. What are we going to do? So, pardon me. So this is looking at the action of buprenorphine at the cell site of the mu opioid receptor as well as the kappas. We'll forget about the kappas for today. And so essentially, when somebody comes in and they're in withdrawal, there is a portion of their mu opioid receptors that used to have a ligand attached to them, a full agonist ligand. And now that receptor site is unoccupied. It is not all receptor sites that are unoccupied. That happens after we give somebody a lot of naloxone. We would have all of their, in theory, all of their mu opioid receptor sites free of ligand. But when they're coming in withdrawal, there's a portion that is open. And that's very important because depending on the agent that we choose, that can be very, very important. So with this particular molecule, methadone, when we have a patient who has some of their mu opioid receptors with a full agonist on them, we can add methadone with relative impunity. So we could add a typical starting dose of methadone is between 30 and 50 milligrams orally once. Sometimes people will start at 10 or 40 pardon me, 30 or 40 milligrams, and then give a second 10 milligram dose later in the day. But the maximum is that 40 or 50 threshold for the first day. And what this does is some of those unoccupied mu opioid receptors become occupied with this very long-acting full mu agonist, and the person feels better significantly. Okay. What we do to improve the situation and improve the safety of somebody with methadone is we increase the concentration of methadone that's available to them. The dose for treatment for methadone these days, I don't even think we've established a ceiling. When methadone was first introduced, 60 milligrams might have been the ceiling for daily sort of methadone maintenance treatment. Back when we used to call it that. These days, you don't even really see a significant effect on their cravings until we're at somewhere around 90 milligrams. 120 milligrams, 140 milligrams. These are usual doses for people who have been using fentanyl for any significant period of time. Pregnant women or pregnant people, pardon me, who've been using fentanyl may be on 200 milligrams, typically split. But the ceiling for methadone is ever changing. But methadone is having a moment. It's coming back a lot. Okay, so what we do with methadone is we increase the concentration in order to occupy receptors. At the low doses, we're just trying to treat withdrawal, and we're just adding to some of the action and some of the unoccupied mu opioid receptors. We turn them on. When we're trying to promote safety, what we're trying to do is use concentration to crowd out the other ligands. Okay, so we can actually get a pretty good high concentration of methadone in those 90, 120 range, milligram dosing range. And this increases some safety when fentanyl or other high potency opioids are introduced because there are not as many available open mu opioid receptor sites. I think it's also useful to remember that is incomplete. That's an incomplete statement. When we think about the occupancy of a mu opioid receptor with a ligand like methadone, it's not it's entirely a lock and key procedure where the key stays in the lock. This is a dynamic process that on the millisecond is happening. There's an interaction and they separate. There's an interaction, they separate. So there can be an opportunity for fentanyl and other high potency synthetic opioids to interact with the receptor and cause different effects. So it's important to know that this safety is not complete because it's not a static phenomenon when we do turn on these receptors. Okay. We'll come back to, but yeah, I guess we'll use this because I think I may not come back to this slide. But efficacy is when we talk about full versus partial agonism. And within that full agonism, there is a bit of a differential for the efficacy and how much effect can we get in that cell that we're not even going to really get into once that receptor is stimulated. But affinity is a different property, and affinity is a important property, and it's how buprenorphine exerts its action. So typically, we talked about somebody coming in withdrawal, and they have some of their mu opioid receptors that are occupied by some of the exogenous ligand, we'll say fentanyl. Buprenorphine has an incredible affinity. What this means is that it can push off that fentanyl and occupy those sites. And so if there's a site that has fentanyl on it and we push it off and put buprenorphine on, which is a partial agonist, what we have is a rapid decrease in the downstream opioid receptor effect. So what we have, or what we potentially have, is something called precipitated withdrawal. This is why we need to be careful when we're using buprenorphine, and we can be less careful and using methadone. It's what we need to do is decide at what stage of withdrawal are they in, how many receptor sites are relatively occupied with the full opiate agonist. So can we do buprenorphine induction safely and successfully? So this concept of micro-induction, where we slowly increase the quantity of buprenorphine that's available in the synapse so that we slowly displace and we don't have that precipitated withdrawal. We have a gradual period of withdrawal and get into a maintenance phase where people are happy and healthy and good. So there are many micro-induction protocols, and these are more appropriate when somebody is not in a significant amount of withdrawal because they have mu opioid receptor action at that point. When people are in terrible withdrawal, you can put a little bit more buprenorphine without fear that you're going to cause precipitated withdrawal. You're actually going to treat their withdrawal by that agonism, and they'd take anything at that point. So microdosing has become very popular. This is just microdosing, actually from methadone to buprenorphine, which is something that we thought we couldn't do, but with very small doses. There's even better ways to do it. And it's this way. It's with the buprenorphine patch or the Butrans patch. This is a wonderful thing. We put 20 micrograms per hour, yes, Butrans patches on people. We leave it on for 24 hours. And by that point, they've had this very gentle displacement, and we can go to a more standard buprenorphine induction protocol, or even skip that and get into the big fun stuff. The big fun stuff is this medication called Sublocade. Sublocade is a long-acting injectable form of buprenorphine. So it's a LIOA, long-acting injectable opioid agonist. That's the non-branded version of this. This medication is wonderful. It's equivalent to a dose of between 24 and 32 milligrams of buprenorphine sublingually per day when it is started. However, what we do is we take 15 minutes of willingness and we can change it into a month of safety. It lasts for approximately 30 days, up to 6 weeks in some people. And it's a wonderful way for us to be able to go from one to the other. It is my hope that we could eventually do the transition of somebody who's in withdrawal and before they leave could be given Sublocade. There was a time in my office, a day in my office, I did 3 doses of naloxone and then a shot of Sublocade and sent them on their way. Much more carefully than that and much more scared on my part than that. But it was an incredible day where we took somebody from a very dangerous situation and protected them for 30. Okay. Useful points as our time is starting to get away from me a little bit here. So methadone is a full agonist, and concentration is the game it plays for increasing safety and decreasing the interactions. And buprenorphine uses its strong affinity. And I think there's a chat question. So Suboxone is buprenorphine. So buprenorphine slash naloxone is the branded oral preparation of sorry, I've lost where I was with my statements. But so, yeah, so Suboxone, that's what we're talking about. And so Sublocade is just the injectable form of Suboxone. There's no naloxone in it, but the naloxone doesn't actually have any significant activity. It's there for safety. When people are given Suboxone, they dissolve it under their tongue. And the buprenorphine is absorbed buccally, but the naloxone is degraded in the mouth, or when it's swallowed, degraded in the stomach acid and the pH of the stomach. So, okay, back to Jay. So Jay eventually was transitioned to long-acting injectable buprenorphine. And there was some significant improvements into how things went. He's doing pretty well. He was trying to stay, trying to walk the line as best he could and doing as well as he could. Unfortunately, started using a lot more methamphetamine. So I started to feel like this guy. This is my second Greek mythology reference in the presentation. My kids are into a podcast right now, and I've been learning a lot about it. This is Sisyphus, and his punishment for evading punishment from the gods twice is to carry a boulder up a hill. And by the time he gets there, the boulder's back at the bottom, and he has to do it over and over again. And it was probably around this time, or I don't know when, but I felt like I wasn't helping Jay. Despite my best efforts, things were clearly getting worse. I was using more meds. He wasn't probably going to die of an opioid overdose, but I couldn't objectively say that this guy was doing better while under my care. Well, poor me, I guess. And in comes contingency management. Contingency management became what we could use now, because for methamphetamine use disorder, there's a whole bunch of poorly functioning medications that we can use. One of them, kind of the mainstay, is bupropion. Remember what happened when we started bupropion just for nicotine use disorder? That wasn't going to work. So we had to use something else. And luckily, what we could use is the best thing available. The best thing available is a strategy called contingency management. It's the best thing available for stimulant use disorder. It's a psychosocial intervention that we don't know about and that we don't use very much. So what it's trying to do, hopefully this slide works, is reprogram. What we want is kids, young people, have been getting a bath of dopamine into their nucleus accumbens and up through the prefrontal cortex from using drugs. What I'd like is to establish a bath of dopamine, or possibly a little sprinkle of dopamine, from not using drugs. How do we do that? And so what we do is we use two tools. There's urine drug screening and there's a fishbowl. That's the typical method. That's not what I use, but for all intents and purposes, what we end up doing is somebody comes in and they give us a urine sample. If their urine sample is negative for the substances of interest, they get to reach into the fishbowl and pull out a prize. They look, they open it up, they see the prize that they got, and they get dopamine from not using. And we're trying to reprogram and give their brain a different option. So, this is the kind of headline that you get, pay drug users to stop using. That's what I do. I don't even necessarily pay them to stop using. I just pay them to show up, and I pay them to submit samples, and I pay them to try. And so it's a wonderful addiction treatment. It's the best thing out there. There is, in terms of the effect size and how frequently it works, these are both, contingency management beats everything, both for stimulant use disorder in adults and cannabis use disorder in adults. It's the only thing that we've got for stimulant use disorder in young people, so we better be trying it a lot more. How it looks in my office is people, initially I wanted to have the fishbowl method. In the fishbowl method, these are largely done by VA data from the United States, the Veterans Affairs Office. They do a lot of these experimental they do a lot of the evidence gathering for this method. They have a fishbowl, and some things have prizes, other things have motivational quotes, yay, and they tell us how many prizes need to be in the fishbowl relative to the other things in the fishbowl and the try again some other time statements. But I was having a hard time getting buy-in from young people for maybe a prize, because they feel that their privacy is being a little bit undermined when I'm doing urine tests on them. If they submit a sample in a bottle and it is human urine and it is warm, they get $5, Amazon $5. It goes in their email, they see it, they get the ping, you see the dopamine, they feel proud of themselves. If it is devoid of substances of which we are interested, they are eligible for a $5 or $10 bonus of Amazon dollars. So I pay them to not use. And it works. So this poor boy, It's not necessary to, yeah. So he had the additional trauma of a lost parent before he even got to his 20s. Um, but he shows up to every visit. He comes, he's excited. He did, we did a sort of 3-month trial of the of the contingency management where he was getting paid for his urines. He still likes to come and do urines because he feels good when they're negative, and I'm not even paying him anymore. And so it's this wonderful thing where we continue to have a relationship. Contingency management has helped him be proud of not using and to feel good about not using. So I still don't know if I'm doing the best for Jay. However, he can vote with his feet, and he continues to come. And so that's the conclusion question mark for Jay. And just for maybe some take-home points, polysubstance use is the rule, not the exception. And so a good question is, so what else are you using? If we've been able to establish somebody's history, this is a great place to go. Benzodiazepine withdrawal is life-threatening and needs to be treated. The endpoint for treatment is difficult. I don't know, but we have to do something and not nothing. Opioid withdrawal syndrome is not life-threatening. However, there should be a caveat to that, because if somebody goes out and uses fentanyl in response to a significant amount of withdrawal and they overdose, could that have been prevented? Probably. So, yes, and we have options for opioid withdrawal, and contingency management works. It's great, and it's actually super fun. So that is the conclusion of things. I think we got the useful references teased out of that, and I hope that that is good. And I think we're close to time. And let me stop my share and start addressing the chat. Is that a good way to go? And anybody can ask questions if they have questions.
Yeah, perfect. There's a few. Thank you so much. That was a really, really great, informative talk. Sorry, I'm jumping to the questions already.
Yes.
I'll just give you the few chat ones. While other people have questions, they can raise their hand. So the first one is somebody was wondering about Suboxone use.
Yes. So I think we sort of addressed when I was talking about buprenorphine, I was trying to do the thing where we don't say the brand name that everybody knows and make it more confusing for everybody. But Suboxone is a wonderful withdrawal treatment. However, we need to wait for somebody to be in a significant amount of withdrawal to start them on Suboxone, unless we do it in what we call a microdosing protocol, and they can be in a little bit less withdrawal, which is good because they're less likely to run away in that phase. But Suboxone is a very useful tool. It just needs to be used a little bit carefully. However, it should be the first choice because of the long-term. It is a wonderful long-term choice. It's a better long-term choice for young people and adolescents in terms of treating their opioid use disorder. And treatment of opioid use disorder begins with medication. It's not, we don't try some other things first. Treatment of opioid use disorder is Suboxone and methadone.
Great.
Sorry, I get preachy. I apologize, everybody.
Okay, next question. First of all, thank you for the timely talk. Another thank you. Can you comment on the role for pharmacogenomic testing in substance use disorders and management of withdrawal? Is this underutilized? Would this info help clients and care providers in managing these issues? And does it inform the risk of for patients? Example of overdose are PGX panels, example for treating depression or substance use disorders covered on provincial health plans and accessible outside of CAMH. And then there's a second part to the question.
Yeah. Oh, wow. That's an awesome question. I think that's a great question. I don't know that I don't know that there's a significant genetic susceptibility to overdose of opioids or benzodiazepines that is super relevant, because of the nature of a lot of overdoses is accidental. A lot of overdoses is accidental. And knowledge doesn't avail us much in those situations. However, it's super useful because when we talk about, I didn't get into my discussion about the overall substance use and concurrent disorders treatment, it's based on a pyramid. We're focused right at the top of this pyramid, but we have fundamentals, we have mood and anxiety disorders, we have ADHD and school support, and then we have substance. And so for the lower tiers, absolutely, genomic testing is super important and valid so that we make good choices faster, so that we can more adequately treat the underlying depressive or more likely generalized anxiety disorder illnesses that are present. I don't know about access. I apologize. And are youth accessing the free public health testing of drugs? Not nearly as much as you'd like. Unfortunately, there's stigma. I didn't show the stats, but one of the things that happens with the very youngest brackets, both in the Ontario and national data, is that these people die alone at home. And that's largely because it's partly because of stigma, because young people can't use drugs with impunity. That might be a protective factor, but we also have to realize with that protective factor comes use alone, clandestine use, and higher risk of death from accidental overdose.
We jump to, there's a few questions about cannabis.
Yes.
So looking for words of wisdom about cannabis, or options for patients who want to stop cannabis use.
Yeah. Okay. So cannabis use disorder is a challenge. Again, we sort of do need to look at the full pyramid of substance use and concurrent disorders and make sure that we're adequately paying heed and making sure that there's good treatment for those lower tiers, the basement being fundamentals of sleep, nutrition, exercise, anxiety, and mood disorders. But when we're talking about cannabis use disorder specifically, we can use contingency management. I have some dipsticks in the office that have 5 levels of cannabis, so they're eligible because the cannabis will be positive for so long. And you don't want that bonus for doing well to be too far off in the distance, because it could suffer from this. If it's not right now, it's forever. It's never. And so when they cross a level, they get a bonus. So contingency management works. And N-acetylcysteine is our sort of number one go-to tool. It is on the border between a drug and a supplement, but we use N-acetylcysteine PO, 1,200 milligrams, BID. Start at 600 because it's tough to tolerate, but once they're tolerating 600, get right up to 1,200 BID, and see how that goes. But continue the relationship and make sure that the whole pyramid is being addressed.
Thank you. Thank you again, and there's so many words of thanks in the chat, both for the talk and for the work that you do. And so, on behalf, thank you so much for this. Unfortunately, we've run to the end of time, but I'm sure Dr. Kelly is happy to answer questions offline. But that was super informative and really helpful. So thank you so much.
Well, thank you so much for having me. I apologize. I struggled in this format a little bit, so if my nerves got the best of me, but I really appreciate everybody being here. Thanks so much, and I just anytime, please. I love questions and all that good stuff.
It was a great talk. Don't think it was the best of you. You were excellent. So thank you again.
Thank you. Bye, everybody.